All right, welcome everyone. We're back for another dose of Joint School Live. And with me today, I have Dr. Ihekweazu coming to us from Houston, Texas.
Thanks for the invitation. Happy to be here. Looking forward to it.
Yeah, hey, thanks so much for joining us today. And so today, we've got a bit of a special session where we're going to be digging into the concept of technology-assisted joint replacements. So there's a few different things to touch on here, and I know it's something that we've had some really great suggestions about and some questions on. So, as ever, thank you for sending in the questions. And this is it. We're digging into your topic. But before we do that, Dr. Ihekweazu, can you tell us just a little bit about yourself and, who you are, what you're doing, what you're bringing to this virtual table, so to speak?
Absolutely. Like I said, happy to be here. I am a hip and knee replacement surgeon that's based in Houston, Texas. So I'm actually originally from Houston. Did a lot of my training here in Houston, but also in New York City. And I'm, kind of a native Houstonian, native Texan. So Texas was always going to be home for me. I'm a part of the Fondren Orthopedic Group, which is a large private orthopedic surgeon group here in the Houston area. And I primarily practice out of Texas Orthopedic Hospital, which is an orthopedic-only hospital. We do nearly 3,000 joint replacement surgeries here a year, so it's a very high volume, busy practice. And all I do is take care of hips and knees all day, and I love it.
Yeah, sounds good. Hey, thank you so much for taking the time to join us.
Absolutely.
So, well, I guess we might as well begin at the beginning. Like, what is technology-assisted joint replacement surgery, or what do we mean when people use that phrase? What does it cover?
So there's kind of two branches of joint replacement surgery at this point. There is surgery that uses sort of conventional conventional instruments to make the bone cuts and align the implants in a way that is biomechanically sound for each individual patients. And these are the ways that we've been doing hip and knee replacements for the last many decades. Technology in joint replacement surgery was originally introduced a couple decades ago and has evolved, in particular over the past 15 years or so, has evolved substantially. There's different types of technology. There is computer navigation, where we use a computer that's calibrated for a specific patient during a specific type of operation, and that helps us align the implants in a certain way that's helpful for that patient. There's robotic assisted surgery, where we use a computer to sort of help create a sort of 3D model of a patient's anatomy, and then use a robot arm, like a robotic arm that has a saw or burr, that helps us to execute that plan. And then one other technology that's been around is patient-specific implants. That's where we use a CT scan that's used prior to surgery to generate a sort of 3D printed bone model for a specific patient, and we're able to make specific cutting guides that allow us to perform that operation for each individual patient. So, excuse me, a lot of different types of technologies that are out there. These continue to evolve, but that's kind of what's out and has been used in most patients.
Okay, yeah. So you've touched on quite a few different things there, and so well, in your day-to-day practice, which of these technologies is it that you would use most personally?
Yeah, so each case and each patient is completely different. For me individually, when I do a partial knee replacement, so that's different from a full knee replacement in that we're just replacing one part of the joint. For my partial knee replacements, I exclusively use robotic assisted surgery. That's the way I was trained to do these operations, and that's the way I can most reproducibly get a result that is able to align that patient's anatomy in a way that is specific and normal for that patient. So that's what I do for my partials. For my total knee replacements, I would say about 60 to 70% of my knee replacements are done using some sort of computer navigation. And the reason why not all of my patients or surgeries are performed with computer navigation is because, in my opinion, for my practice, it's not necessary for all patients. The purpose of a navigation aid is to help us as surgeons be able to have a specific roadmap for how to align a patient's joint. Regular knee replacement surgeries, for patients that have standard vanilla run-of-the-mill arthritis, navigation systems aren't necessarily needed or required for all patients. Now, if you're someone that has complex anatomy, or if you've had previous surgeries before where your bone alignment, or there might be hardware screws that are in your femur or your tibia, that sort of makes the surgery a little bit more technically challenging, that's where navigation tools may be of benefit. The vast majority of knee replacements and hip replacements are done without navigation aids, and the vast majority of these operations are done very successfully. So, for me, about 60 to 70% of my knee replacements are done with computer navigation, but those are specific cases, even though it is the majority, but generally those patients have some sort of anatomic challenge that the navigation system does help with. For my hip replacements, I would say I use some sort of navigation tool in about 30 to 40% of my cases. Primarily, the tool that I use is a computer navigation program that helps me align the new hip socket in a position that is specific for each individual patient. So, but again, it's a tool. It's not the most important part of the procedure. It's a nice aid that is available to us as surgeons.
Yeah, interesting. And so, well, if you pardon the pun, you mentioned that not all of the operations that you do will involve these technologies. So how do you navigate that conversation with a patient who perhaps might come to you and say, well, I really want a computer to be involved, or I've heard about this, cool stuff, or maybe, alternatively, someone who feels a bit uncertain about a computer somehow being involved in the operation?
Yeah, great question, and I appreciate the pun. Yeah, so I think ultimately what surgeons try to convey to their patients is what matters is functional outcomes after surgery. We want, and I always tell this to my patients all the time, you as a patient have a diseased knee or problematic hip that has taken away from your quality of life. Ultimately, our goal is for our patients to forget about their hip or forget about their knee and go on living their lives the way they feel like they should be living their lives. And in order to achieve that goal, we need to be able to create a hip or create a knee that is biomechanically sound. And for most individuals and for most surgeons that do a lot of these operations, so we're talking about people that specialize in joint reconstruction and do a high volume of these operations. For most of these types of surgeons, we can accomplish this without any fancy equipment or new technologies. What the new technologies do help with is yielding results that are reproducible. So there are studies that show that when you use computer navigation or robotic assisted technology, or even patient-specific implants or instrumentation, the alignment that's achieved from these technologies after surgery is better than the alignment that can be achieved by using conventional instruments. And when I'm talking about alignment, I'm primarily talking about what we as surgeons see on x-rays. So did we get your mechanical alignment from your hip down to your ankle perfect, essentially? And, with new technologies, you can get that down to a single degree or even millimeters of being as perfect as you would want. And that's great. But the question then becomes, does that degree of accuracy translate to improved function for the patient? Patients don't look at their x-rays and the x-rays don't dictate or determine how you're going to feel, how your joint's going to feel. And to date, there's been no data to support, or there's been no data showing that new technologies provide better function for patients than conventional implants. So when I sort of talk to patients prior to surgery and talk about the new adjuncts that are out there for their surgeries, I really try to make it clear that these new instruments and these new technologies are meant to make sure that we can align your joint in a way that we think is going to be beneficial to your function and long-term survivorship of your knee or your new hip. But the data is not quite there yet. So what I always tell people is have a conversation with your surgeon. Make sure you trust your surgeon. And if your surgeon feels that he or she doesn't need a new technology to reconstruct your hip or your knee in a way that will provide the best function for you, then I would trust that surgeon, especially if they're someone that does a lot of these operations. Because the truth is that we can do these operations with or without these new technologies, and by and large, we get excellent results with that.
Okay, interesting. And so you've touched on there on how these adjuncts, these assistive technologies can use perhaps to overcome challenges of a particularly complex case, or or to sort of differentiate to more unique anatomy and to help with alignment. But from a patient's point of view, how is the experience different? If one undergoes a computer-assisted or computer-navigated hip replacement or knee replacement as opposed to without?
So ultimately, the experience should be very similar, with some deviations from that. So when speaking about computer navigation and patient-specific instruments, the experience for the patient is largely the same. During the surgery, you're asleep and you're not aware of what's happening. If that surgeon is new to a specific type of technology, so say this is her first time using computer navigation, or his first time using a certain type of patient-specific instrument, it could make the actual operation itself a little bit longer.
Okay.
And which is not ideal. We want these surgeries to be done as efficiently as possible so the patient's not under anesthesia for a long period of time.
Yeah.
But as a patient, if you're under anesthesia, you're not really experiencing time or even experiencing surgery. So by and large, your recovery after surgery should be the same as it would otherwise. Obviously, if something goes wrong with the surgery, then that's a complete deviation. With regards to robotic assisted surgery on the hip side and the knee side, typically some sort of a tracker or a bone tracker is necessary for these cases. So you might see that your surgeon has to put in some pins outside of where the usual surgical field is. So with regards to a knee replacement, sometimes the surgeon has to put pins in your shin bone, which is your tibia, or pins in your thigh bone, which is your femur. And so you might have some secondary incision marks that are outside of the usual surgical field. On the hip side, sometimes it's necessary to put pins into your pelvic bone, which is above your hip joint. So you might see some incisions that are outside of this area. But the recovery process, there's been no studies that have shown any sort of deviations from recovery in better or worse. They're pretty much the same for patients receiving these.
Okay, that's interesting. And so with these pins and perhaps other things that are required to sort of position these instruments or adjuncts, depending on what's used, are there any like potential or possible complications or any sort of additional risks that need to be discussed with these technologies?
Absolutely. So on the robotic side, the pins can cause problems, right? So anytime you make an incision anywhere in your body for any type of surgery, there's a risk for infection, there's a risk of wound complications. So if you're talking about adding additional incisions outside of your knee replacement incision or your hip replacement incision, that increases the risk for a complication related to those pin sites. And sometimes there are problems with pin sites. So that's something that you would want to talk to your surgeon about if you're undergoing a surgery that is robotic assisted. For the computer navigation and the patient-specific instrument procedures, those routinely don't require additional pin sites or additional incisions anywhere. That said, if I kind of alluded to this earlier, if your surgeon is not facile with these techniques and doesn't have familiarity with the instrumentation, it may add additional time to the procedure. And every 10 minutes or 30 minutes added to a surgical procedure, that's more time that your body or joint is exposed to the environment. And the longer surgery goes, the more likelihood that you may have complications or run into issues like infections after surgery. That's something to consider. So if your surgeon is proposing use of a new technology, you want to make sure that that surgeon has excellent training and that technology is certified, and that the new technology won't significantly slow down how quickly they can perform the operation in a safe manner.
Okay. And you mentioned that it's these sort of adjuncts, these assistive technologies are not always required, not always necessary, and indeed you don't always use them. But are there some cases or some situations where it wouldn't be appropriate to use it, or or like what one might call a contraindication to using some of these?
So I wouldn't say that there would be any specific contraindications to using a technology that is separate from your standard contraindications to undergoing any sort of joint replacement surgery. That I can think up off the top of my head. We typically don't use these technologies for revision operations where we have to take out an old implant and insert a new implant. There are actually situations where we do, and where it may be beneficial. So I wouldn't say that there's any that come up with that. It's not routinely used that way, but I wouldn't say there's any contraindication.
Okay. No, and I know another question that we've that gets sent in from time to time about more specifically about robotic surgery, I guess, is that some people, and this is kind of alluding and similar to those who are a bit concerned about a computer being involved somehow, and then sometimes I guess people are a bit uncertain about how much of the operation does the robot do, and that kind of that side of things, which I'm sure is a question that you've had a number of times as well.
It's hard to kind of picture what occurs during the actual operation when we're talking about robotic assisted surgery. So what's for example, the Da Vinci robot, which is used in general surgery and obstetrics and urological procedures, has been around for many decades. And with that technology, the surgeon's actually outside of the surgical field, and they're controlling the robot from a remote place. For what we do in orthopedic surgery, our robotic technologies are assisted technologies, meaning that we are controlling the actual robotic arm, and we are controlling its movements with the assistance of the robot that is helping us to achieve our preconceived plan for that specific patient. So the robot is under our control at all times. If we decide to stop the button, then the robot doesn't move. It's an incredibly safe technology. And to my knowledge, there hasn't been any issues with it. So it's something that can be hard to sort of picture as a patient, but the surgeon is under the control, is controlling the robot, and is in full control of what's happening in the operation. That said, when I always talk to patients and people in the community about these new technologies and robotics in particular, your surgeon has to be well-versed in arthroplasty and joint replacement type procedures. The technology is not a replacement for experienced hands. If your surgeon doesn't understand the complexities of alignment and soft tissue tension during the operation, the robot won't compensate for that, because essentially what's happening with these surgeries, robotic, patient-specific, and computer navigation, is that as surgeons, we are creating a plan we're using these new technologies to give us back objective data to help us create that plan, but ultimately we're creating a plan. So if our plan is wrong, the robot will help us execute a wrong plan. So at the end of the day, your surgeon has to be someone that performs a lot of these operations, is very comfortable in doing joint replacements, so that we can use our own experience knowledge to help the robot give us objective data, so that we can use that data to create a plan that works well for you as a patient.
Yeah, absolutely. I really like how you phrased that. I mean, and it's so true. I'm going to steal it, in fact, I think. So for any of these three types of assistive technologies that we've discussed, that assistance is no replacement for experienced hands. I think that's very well put.
Absolutely.
But something that you've also touched on is that these assistive technologies are not always available. In fact, for most of joint replacements that happen in the US, here in the UK, all around the world, are currently not using these assistive technologies for various reasons. So what would your message be to those people who might be watching this now, who are getting ready for surgery, like trying to learn about what's the different things to do, what not to do, and what's going to happen, and may or may not have access to, or maybe booked in for an operation where they know it's going to be done sort of without a sort of specific implant that's sort of matched to their anatomy, or with computer navigation, or with a robotic arm?
Absolutely, great question. So what I would say is we don't need computer navigation or assistance from a robot for any arthroplasty procedure. So when I say arthroplasty, I mean replacement. Yeah. Any replacement procedure. It is a complete adjunct, meaning that it is something that helps us to execute the surgery, but we don't need it. A nice analogy that's often used is GPS when you're driving a car, yeah. Right? GPS has been around for a couple decades almost now. But before GPS was around, we could perfectly drive from point A to point B without use of Siri telling us where to go, right? We can get there. Nice to have GPS. It tells you about traffic patterns, and if there's a road blockage, it can help you navigate around it. But there's also these things called, street signs and, other things, directions that can help also guide you there. So it's an adjunct, but it's not altogether necessary. And I will continue to say that in terms of what the patient experiences, in terms of your function of your hip and your knee, there's been no data to suggest that new technologies are better than the conventional instruments. There might be some new data that comes out, and we're continuing to study this, and that new technology continues to evolve and it continues to get better. But to date, there's nothing that says that it's better. So if you're in a location or in a region where your surgeons don't have access to this, but your surgeons are also very experienced in joint replacement surgery and they get great results, then I would defer to your surgeons because they're going to do a great job. So that's what I would say. It's a nice adjunct. I'm particularly interested in it because I'm at the outset of my career, and just like with any new technology, it will continue to improve, and I enjoy being a part of evolution of new technologies and new materials, and that's part of the reason why I incorporate it into my practice and use it for my patients. But there are certainly many senior surgeons that are out there that don't utilize these technologies that achieve outstanding results in their patients. So ultimately, what it boils down to is, and I always give this advice to patients, is choose a surgeon that you communicate well with, that you trust, that has excellent outcomes, and does a lot of the type of operation that you're needing, and you can't go wrong.
Yeah, absolutely. Comes back to those experienced hands again. Yeah. Absolutely. Well, I've really enjoyed this conversation, and how we've navigated the topic of computer navigation and beyond. Is there anything else that you would like to add before we sort of call the session to a close?
No, I'll continue to reiterate that at the end of the day, what matters is that you communicate with your surgical team, that you choose a surgeon or a hospital that has a lot of experience in the operation that you need. if technologies are utilized, you want to make sure that they have a lot of experience using that technology. You know, it does introduce new variables to the surgery that wouldn't be there otherwise. So with new variables, there's potential for improvements, but there's also potential for complications. So you want to have a conversation. You want to be well versed in what they're going to do for your surgery. And if you have questions, most surgeons, most surgical teams should be always open to answering any questions that you might have as a patient. So.
Yeah, absolutely. And that's something that we come back to again and again, sorry, in these videos, is that, you know, it's about the conversation that you have with your surgeon and the team. You know, they'll be more than happy to answer any questions that this session may have sparked, or and also for that matter, if you have, you know, we're also very happy to receive questions, non-clinical and not about your care, but sort of general themes, general topics that you would like us to dig into. If this video has sparked any more questions around this, or is there anything else for us to dig into, let me know. As ever, you know, contact us and we'll get to it. But one final question, if I may. What is your, you know, as a surgeon who, you know, as you've said, you're interested in this field, and you want to be part of the evolution of new technologies coming into orthopedic surgery and joint replacement surgery. Where do you think the next big innovations will be? Like, if, let's say we had a crystal ball and we could look at your practice in 20 years' time, what do you think may be different in terms of your future practice?
Yeah, it's pretty interesting. I think we continue to be in a place of evolution in joint replacement. And over the last 5 to 10 years, there's been a lot of focus on how to get patients out of the hospital quicker, help the recovery be a little bit smoother with less pain involved, and help people get back to their previous level of activity a lot quicker than they were otherwise. Some of these newer technologies that are available to us, as these new technologies improve, we can potentially rethink how we make the implants. And in terms of robotics in particular, there may be room for us as surgeons to be able to create implants that more closely resemble what that specific patient's knee looked like prior to their arthritis or their sort of degeneration. So things that over the next decade, maybe a couple of decades, with other adjuncts like 3D printing and newer biomaterials that may be available to us in the future, that we might be able to introduce to patients to ultimately get patients back to where they were prior to their disease state, and also provide a joint that will be long lasting and very durable.
Yeah. Well, interesting. So, well, watch this space, I guess, and exciting times ahead. Well, hey, Dr. Ihekweazu, thank you so much for joining us. It's been a really great conversation, and as ever, everyone out there watching, thank you. Let us know what you thought about the session. Send in any questions, and we'll see you next week. Take care, everyone. Be safe. Bye-bye.